research and development in the cardiovascular arena is still very much robust. Certainly the direction of all these newer technologies is designed to provide treatment at great outcomes, but with a lot less burden on the patient. You know, it's all about minimally invasive. It's all about enhancing outcomes. And then ultimately the job of all these things as we go through and test them and refine them and so on is to improve cardiac performance, reduce the risk of heart attacks and strokes and things of that nature, and ultimately improve people's lives. So with that, I say thank you, and I'll be happy to take any questions.
Lower the high blood pressure, like marching up the hill in Rancho San Antonio, walking on the beach in Half Moon Bay, and all that, on a regular basis, I mean, like several times a week?
Yes, so it sounds like a really good recipe. So the question, if you didn't hear it, was the types of exercises one can do to lower blood pressure. And aerobic exercises, walking, jogging, treadmill, bicycle, whatever you will do on a regular basis is definitely the recipe. The minimum threshold for cardiovascular fitness is getting your heart rate to 75%, 80% of your predicted maximum for 20 minutes, 3 days a week. And that's going to go off, I'm sure.
Code blue, new main hospital, progressive care unit. Code blue, new main hospital, progressive care unit.
So that you are never at the other end of that call, I would advise that you do it more than just 3 days a week. Give your joints a break a couple days a week, but you know, the goal is to, you know, as much as you can tolerate beyond that 20-minute threshold, you know, more like 5 days a week is a great way to lower blood pressure and create cardiac performance. I know Dr. Nouri will speak in that direction quite a bit as well.
I just want to add that most people think they're on high blood pressure, they can eat whatever they want. They don't pay attention to the low-sodium diet. That's more important.
Yeah, the diet is definitely important to blood pressure control, and you know, there have been differing opinions about salt in particular over the years. You know, the bottom line is that, you know, there are some people that are more sensitive to salt than others, but there's probably nobody in this room that needs to be ever having a salt shaker in their hand. So if you are, stop. If you're using salt replacements, those are usually potassium chloride, which is also potentially dangerous. So if you're replacing salt, you're just replacing one thing that's probably not so great with another. Go to pepper or go to something else, some other spice that actually doesn't hurt your blood pressure.
And I've been told to have more salt in my diet.
I'm not going to comment on who said that, but that person seems to think that they are smarter than the person that put us together in the first place. Your body was built and designed and has been refined over many, 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 many years to manage its salt metabolism just fine. So if you're healthy, you don't have to add salt, certainly.
What about your trials? I noticed that you were looking for patients. How do you find out about the trials?
These trials are all accessible on the hospital website. If you go under the Norma Melchior Heart and Vascular Institute and or the link, or directly or by link to the Fogarty Institute, where all the trials that we're active in, and their contact information there. Thank you.
Hi. Since heart problems tend to be at a time when there's a confluence of other problems, what conditions would preclude somebody from being involved with the VPD?
Typically, the patients that are candidates for ventricular restoration are those that have had a prior heart attack. They've got diminished cardiac performance, so their ejection fraction on an echocardiogram would be reduced, and they are in either stage 2, 3, or worse heart failure, so a lot of shortness of breath, already maxed out on medications. You know, all the other stressors of life and other comorbidities. As long as you're not on dialysis or something of that nature, then usually you would fit into that type of a study.
But
everybody else. I mean, usually the main exclusions are age greater than 90. Nothing against the nonagenarians, it's just that they need patients to reliably be around long enough to see the effects. Advanced kidney failure, or some other health problem that would limit life expectancy to less than a year.
I'm curious about the bypass stent. How do you attach the artificial stent to the organic arteries on either end so that they don't get rejected and obviously the connection's secure?
Mm-hmm. Good question. Much like the valve that I showed you earlier, the architecture of those stent grafts is also nitinol. So it's that same self-expanding metal that we use day in, day out in the vascular space. The coating that is used is, there's a couple different polymers that we work with, polyethylene and PTFE. These are basically inert plastics that are non-porous. They've been tested extensively for their biocompatibility. The body doesn't reject them because it doesn't even see them. It's just like becomes a part of the patient's body.
Is there a connection between scarlet fever as a youngster and a valve issue as a senior?
Rheumatic fever, absolutely.
But not scarlet fever?
Not so much.
Not really?
No. I don't know that we see that anymore. I think that one's been kind of stomped out.
Is the presentation available on the website?
I believe it is. I think they're streaming it, and it is available.
Oh, good.
All
Okay.
right.
I have another question. I have low blood pressure. Am I at risk for heart disease?
No, you're at risk of people being jealous of you. All right, in the interest of my other speakers, I will kindly exit stage right, and thank you.